Okay, we're going to talk diabetes insipidus. Diabetes insipidus, also known as DI, not to be confused with diabetes mellitus. All right, diabetes mellitus type 1 is like we don't have any beta cells. Usually we detect this as children, and we figure out that this patient does not produce insulin, and therefore they will need to be on insulin therapy forever. That's type 1. Diabetes mellitus type 2 usually comes on later in life as a result of abdominal obesity, diet, lifestyle. And generally, with type 2 diabetes, they are on metformin and other anti-diabetic medications. And in the most extreme cases, they'll go on insulin. All right, that's diabetes mellitus. Now, diabetes insipidus, right, is, so I like to usually think of diabetes like hyperglycemia, but that's not really the case here with DI. It's got a whole different mechanism of action and different pathophysiology. So let's talk about what this is. All right. Usually with diabetes insipidus, someone had an injury to the brain, some kind of trauma to the brain, or maybe there's a pituitary or a pituitary gland tumor. Okay, so we could have a tumor, we could have a trauma, but something causes the pituitary gland to not behave the way it should, all right, which could then impact the production of aldosterone or ADH. Okay, so with that said, a patient who does experience that particular damage to the brain and therefore is not producing ADH, right, will experience these symptoms, polyuria and polydipsia. And that is why we call it diabetes, okay? Not because of the hyperglycemia, but because the symptoms show up looking like diabetes. The polyuria, polydipsia. Remind me really quickly of what polyuria and polydipsia are. Okay, so polydipsia, excessive thirst, so we're drinking a lot. Poly, dipping into the water canteen. All right, polyuria, too much urine. In other words, we're peeing a lot. Makes sense if you're drinking a lot, you're peeing a lot. All right, because something's going on with in the case of diabetes insipidus, salt levels. Okay, hypernatremic people pee a lot. Okay, hyponatremic people, as we mentioned before, pass out because they don't have enough volume. Okay, so hyponatremia, you get dizziness and orthostasis, but with hypernatremia, you're just constantly that kidney is just trying to accommodate having no or too little ADH. All right. Now, I'll talk a little bit more about ADH in a moment, but here's the replacement hormone, desmopressin. All right, the presins, it could be called vasopressin or desmopressin, but they end in pressin and they only treat DI. Okay, the pressins, they only treat diabetes insipidus. And mainly what they're doing is causing ADH to be created more. All right. Now, when you're taking, again, as we've said earlier today, with all these endocrine issues, when you take too much of the replacement therapy, you can drive the person into the complete other direction on the other side and create hyponatremia. All right, so we want to keep them in a balance. So, what are the symptoms of diabetes insipidus? Constipation, weight loss, high urine volume. So, why would someone who has a high urine volume be constipated? Is there a connection? Yeah. Yeah, absolutely. So we don't have enough fluid volume to balance, right, the available fluid in the GI tract. So we get constipated, right? We're putting out so much fluid, we cannot keep a good balance. So will that person be thirsty? Yes, polydipsia. All right, it usually brings extreme thirst, right? It's not just some kind of low-level thirst. They want to replace that extreme dehydration that they have. All right, everything else becomes less important. Decreased sex drive, confusion. Usually, when a person's hyponatremic or has any electrolyte imbalance, confusion is an early sign. All right, muscle pains because we're dehydrated. all of this stuff that goes along with dehydration. But here's something very interesting. High urine volume, super high. Like say people come in on accidents, from motor vehicle accidents, and they've had some kind of brain trauma, severe brain trauma. First thing they will do is put that person, insert a Foley catheter, right? And a couple minutes in, after inserting the Foley catheter, it's full, overfull. That usually gives the folks in the ED an indication that this person may have diabetes insipidus. All right, we have an overfull Foley catheter that's filling up, like the body is not responding to ADH. All right, dry skin, that's another one. All right, so here's the healthy person versus the diabetes insipidus person. All right, so the healthy pituitary gland will send on the HPA axis a notice down to adrenals to create ADH. All right, this is happening constantly. It's happening right now. Our thirst centers are working along with our hydration, right? It's all coming out of the pituitary gland, letting our bodies know, right? Our central nervous system know that we need to either go pee or we need to take in more water, right? We don't even think about it. But so the pituitary gland sends ADH hormone to the kidneys, help control how much urine is made. But in DI, right, we have excessive colorless urine. Notice that the urine is a bit darker here at the, which is average, and it looks like what's normal concentration of water in urine, right? But in the diabetes insipidus person, they're going to have lots of it, right? And it's going to be colorless because it's basically just water, because ADH is about managing the amount of water. All right, so remember, vasopressin, desmopressin replacement for ADH. Too little ADH, we have to replace it with vasopressin or desmopressin, and that will cause the kidneys to begin to function normally again, okay? So because of polyuria and polydipsia, it's called diabetes, but it is not about hyperglycemia here. It's all about urine and ADH, okay? So hopefully I've driven home enough those keywords so that you can make those connections. All right, acromegaly. This is some of these topics I have to find a place to put them because they kind of stand on their own. But acromegaly, this individual has acromegaly. You'll notice his hands are quite large. All right, his head is quite large with a protruding jawline. Okay, so you might get in a person who has acromegaly, larger features on their face as well. All right, their heart might be enlarged. All right, cardiomegaly. They might actually, and it's not shown here, have a enlarged liver. Okay, called hepatomegaly. Okay, so megaly refers to the increase in the size of usually the peripheral, like the head, the feet, and the hands, right? Due to too much growth hormone, okay? Excessive growth hormone. So if pituitary is creating all these hormones all the time, and we have to manage or do the lab so that we can figure out what's going on with these hormones, right? In individuals who show up with symptoms, right? You'll notice that the acromegaly patient has too much growth hormone, all right? We get patients who have too little growth hormone, and those are the little people who are like 14, 15-year-old, and they still haven't gone through puberty, right? Or they are not experiencing it at a normal rate. All right, so what do we do for people who have too much growth hormone? We give them octreotides, okay? Octreotides. Octreotides are pretty much just for slowing down the growth, the excess growth hormone. They have a lot of adverse effects, though. As you might imagine, all of the endocrine medications have a lot of side effects. So there are some adverse events here that could occur. All right, but essentially slowing the growth hormone excess will cause changes to the hands, okay, which tend to be increased in size, the feet, right, the jaw, right, and the soft tissues. So there might actually be reductions in those, all right? But there's a lot of risks with acromegaly. We really keep an eye on these folks. They might be more hypertensive, than others. It could have something to do with the enlarged heart. And an enlarged heart, and heart is a pump, right? So you got an enlarged heart, you're going to have more volume in the body, and more volume tends to go along with more blood pressure. Pressure and volume work together, a little physics. All right, so more hypertension in those folks. They might also experience abnormal glucose tolerance, right? They're secondary to insulin resistance, right? So they kind of go together. All right, so they're insulin resistant, so they might experience some glucose intolerance. So if they're on an octreotide, you're going to watch for stomach upset, GI upset. It's one of the adverse events. Gallstones, all right? There's liver involvement in this octreotide adverse events, right? Bradycardia, which is what? What is bradycardia? Yes, slow heart rate, all right, which could be a result of too large a cardiomegalic heart, all right? Glucose changes will occur in these folks. We teach them to report right upper quadrant pain. Why would we do that? Does anybody have an idea of why? Think about what's in the right upper quadrant. Yes. Liver and gallbladder. Very good. Gallstones are an issue here. So right upper quadrant pain might give us that indication. But also when we have enlarged organs like the heart, we could have an enlarged liver as well. There's also right upper quadrant pain when the triglyceride levels go really high. So we aren't quite sure why there's not one only reason why the right upper quadrant pain comes. It could be enlarged liver, could be too high a triglyceride level. All right, so we monitor, lots of monitoring for patients on octreotides. All right, so that concludes the week 6 stuff, okay?